special report on highlights of the Southern Surgical Association's 80th annual session, brought to you from Boca Raton, Florida. This is Audio Digest Surgery, Volume 16, Number 2, for the week of January 29th, 1969. During this hour, you'll hear 4 outstanding clinical papers, as presented at the session by these noted surgeons: Baylor University's Denton A. Cooley, Johns Hopkins University's Jack M. Zimmerman, the University of Illinois' Lloyd M. Nehus, the Medical College of Alabama's Thomas B. Patton, and in addition, several knowledgeable surgical men will offer their personal comments about the clinical applicability of the presentations. Moderator for this group of papers is the president of the Southern Surgical Association, Rudolph J. Noor. And to begin, here he is.
The first paper on the program, Cardiac Transplantation in Man, by Denton A. Cooley, and by invitation, Robert D. Leachman, R.D. Bloodwell, Grady L. Hallman, and James J. Nora. The paper will be read by Denton Cooley.
While correction or replacement of defective components of the heart has become a standard method of surgical treatment for certain cardiac lesions, generalized myocardial insufficiency refractory to medical therapy can be corrected only by replacement of the entire cardiac mechanism. Experimental and clinical trials of cardiac transplantation already give promise of salvage for patients with advanced myocardial disease. The primary aim of clinical transplantation in each case has been to improve the duration and quality of life. The demonstration that an allografted heart can support human circulation now appears to justify its clinical application in properly selected patients. The purpose of this presentation is to relate to you our experience with 18 cardiac transplantations, 15 of which were done in primary allografting techniques. First, it's important to consider the nature and severity of the cardiac disease which served as the indication for operation. For example, a patient with advanced coronary atherosclerosis. Another patient, a woman who had been desperately ill for 6 months, who had been in oxygen constantly for 2 months. Upon removal of her heart, we found that she had a massive pulmonary embolus, a situation which would have caused her death within a matter of a few hours had this operation not been attempted. Now, if I may show a strip of movie which will reveal to you the technique of cardiac replacement.
The aorta and pulmonary artery have been divided near the heart. The posterior portions of right and left atria with the interatrial septum and orifices of the pulmonary veins and vena cava are retained. The heart of the donor is removed after death, concurrent with removal of the recipient heart. All vascular connections are divided at a distance from the heart, and both atria are preserved intact. The donor heart is neither perfused nor cooled. The donor heart is prepared by opening the right atrium with an incision extending from the inferior cava into the atrial appendage. The incision is not extended into the superior vena cava to avoid injury to the sino-auricular node located at the junction of the superior cava and right atrium. The specialized conduction pathways between the sino-auricular node and atrioventricular node are also preserved. The left atrium is opened posteriorly by cutting between the orifices of the pulmonary veins. A suture ligature is placed about the superior vena cava. An incision is made in the right atrium, extending from the inferior vena cava into the auricular appendage. The posterior portion of the left atrium is prepared for anastomosis by making incisions between the orifices of the pulmonary veins. The donor heart is placed in a reversed position, affording better exposure to facilitate anastomosis. The left atria are joined, beginning laterally and proceeding medially onto the recipient's atrial septum. The initial suture is placed through the adjacent lateral walls of the left atria and the heart lowered into the chest. The lateral walls of the left atria are united by continuous suture. The medial wall of the donor's left atrium is sutured to the atrial septum of the recipient. The right atria are joined by first suturing the medial wall of the donor's right atrium to the atrial septum of the recipient. The lateral margins of the right atria are then attached. Union of the right atria is started at the recipient's atrial septum. The lateral walls of the right atria are sutured. The pulmonary arteries and aorta are joined by continuous suture. The pulmonary artery is trimmed and anastomosed. The aorta is trimmed and anastomosed using continuous suture. Cable tourniquets are loosened and air is aspirated from the aorta and cardiac chambers. A sinus rhythm may be present on removal of vascular clamps. However, the heart usually resumes action in ventricular fibrillation. This has been readily converted to a sinus rhythm with direct current countershock. Cardiopulmonary bypass is discontinued. All blood and priming solution from the oxygenator and tubing are returned to the patient. After use, the plastic oxygenator is discarded.
I think we can discontinue the movie now. Removal of the heart is performed at normothermic temperatures, and the transplant is implanted during normothermic conditions. The summary on the donors: most of the donors have had some form of primary cerebral destruction, either intracranial hemorrhage, trauma, or brain tumor, encephalomalacia, and encephaly. The requirements for a suitable donor are that they must have complete brain destruction, they must have a normal heart, and they must be free of any transmissible disease. Tissue matching was done in each instance, although in some of the early cases it was a retrospective type of study, since these techniques were not available to us initially. At the present time, we are able to do most of these tissue cross-matches prior to operation, but even so, it takes 2 or 3 hours to do one of these tissue matching, and it's not too practical when there's an emergency situation to be dealt with. We don't believe that the tissue matching at this time should be made the overriding consideration in these operative procedures because of the desperate nature of both the recipient and the donor requiring emergency operation. The sex relationships: it is interesting that only one male heart was used in a female. This resulted in rejection. This phenomenon has been demonstrated in the laboratory, where male tissues do not have the same degree of take in female mice as do female-to-female transplants. But this does not prove anything. It does show, though, that most of our recipients have been males. There were 12 males and 3 females. The age relationships: in most instances, young patients have been used for donors for older recipients. We've had 2 patients for donors who are 50 years of age, and this raises a question of what studies should be done on the donor. I believe that any patient more than 40 years of age serving as a donor should have coronary arteriograms prior to using that heart as a donor, because we have in one instance encountered atherosclerotic changes in a donor heart which was unsuspected. This was a 40-year-old donor. We've encountered rejection episodes in our patients, as we had anticipated. The clinical signs of rejection are those usually related to a failing myocardium. In general, they're malaise, fatigability, fever, and friction rub, and other evidence of decreasing cardiac function. The laboratory signs of rejection are of more value to us: the evidence of cardiomegaly, the decreased QRS voltage, the ST to T wave changes revealing subendocardial injury, leukocytosis and increased lymphocytes, the increased enzymes, creatine phosphokinase, LDH1. We have done skin graft, homograph, and then the evidence of decreased cardiac output. The deaths have been caused from infection or sepsis related usually to the immunosuppressive therapy, the presence of pre-existing diseases, acute rejection in 2, and chronic rejection in 3. In summary, these are the results to this time. We've operated upon 12 patients with coronary insufficiency. There were 2 early deaths and 4 late deaths. The initial mortality was 17% among these patients. The cumulative mortality was 50%. In the rheumatic multivalvular disease, there was a late rejection, almost 7 months after his initial operation. The cardiomyopathy was in a 50-year-old man, and he had a rejection episode more than a week after his operation. Endocardial fibroelastosis also resulted in rejection about 1 week later. It's difficult to draw conclusions at this early date. in cardiac transplantation. There are many things of interest and much information has been gained. It is our impression, however, that cardiac transplantation does offer salvage to patients with advanced end-stage myocardial disease. There are many aspects which remain to be tested and studied, such as improvement in immunosuppressive techniques and delineation of proper indications for cardiac transplantation. But I will say that at this time, there seems to be a need for continuation of this program.
Discussion will be opened by Dr. James Hardy.
Of course, if one can remove the beating heart, then he can very well get away, I'm sure, with not using any form of preservation. But this is 3 ways in case one does not remove the beating heart and the heart is stopped with arrest. Cold preservation works quite well, and if one is going to remove a heart that's been stopped already by hypoxia, then perhaps some means of storage is necessary. Most of these hearts will start spontaneously, but one can go ahead and defibrillate them if he wishes. All the transplants, we've used a pacemaker, and with the homotransplants, not. Now, the second method of preserving the heart during transplantation is some form of coronary perfusion. I think this is a technique which Bernard prefers, and of course, again, if one has had the heart stopped with hypoxia, then to impose another 45 minutes or so complete ischemia is to run some risk of having it not start. The third method one may use, which we had investigated and which I believe had been examined at Minnesota some time before, is retrograde perfusion through the coronary sinus. Our conclusions at the moment regarding preservation of the heart is that hypothermia is the simplest. We would use hypothermia by cooling the heart, suturing the atria and the aorta, then removing the air, then open the aortic clamp and perfuse the heart from the pump, and then complete the suture line.
Discussion will be continued by Dr. Watts-Webb.
There are many aspects that deserve comment, but I'll restrain mine just to the immunologic aspects of some of our experimental and clinical work. We found that not only is it important that one match these patients according to the ABO types and also the histocompatibility antigens, but also many of them are going to have circulating serum factors, circulating isoimmune antibodies, which are organ-specific. Dr. Kaplan at our own school at Southwestern, Dr. Hess and Dr. Ziff some years ago demonstrated that after acute coronary occlusions, myocardial infarctions, as many as 30% of the patients will have circulating serum antibodies to heart, which means not only to their own heart, but any heart that might be transplanted to them. And similarly, patients with rheumatic fever, with active myocarditis, as many as 2/3 of these patients may have circulating iso antibodies to heart. We believe at this point that just as in the kidney, the histocompatibility antigens are probably very important for the long-term results. We also must watch for the hyperacute rejection, just as occurred in patients with glomerulonephritis because of the basement membrane antibodies that may be circulating and present. So we feel that these patients, a number of them, particularly those who've had coronaries and perhaps those who've had the myocardiopathies, are going to have organ-specific antibodies, and that such patients can be detected ahead of time by serologic studies, and that these patients probably are not candidates for transplant, certainly at this time and until such time as we can control this hyperacute rejection sequence.
Dr. Henry Bonson.
I don't believe one can really argue about anything. If one is going to argue, I think it would be in connection with his argument against the use of cooling. Certainly in our experience in the laboratory and in our one clinical transplant, there's every evidence to believe that hypothermia is good. And although I realize that Dr. Cooley is the founding father for the Society for the Prevention of Hypothermia, I believe that others of us will be better to use this technique that has been worked out by Dr. Lauer and others, and Dr. Shumway. I also realize that one can't argue and discuss this superb series and the results in this with our one result, who's now 3.5 months. But I would support his statement that this is excellent palliation, and the recovery from a cardiac transplantation procedure, in our experience, the one case was certainly more rapid than following a multivalvular replacement, And his life has certainly been fuller for many reasons, including the attention of the lay press, which this person particularly likes, in the time since he's been operated upon. My only question of Dr. Cooley, namely, has he any further pointers in regard to these patients? I know at one time he was concerned about the activity of his recipients. He wondered if he ought to keep them from running banks and selling cars and the other things that they have been done. It's my belief that this probably makes very little difference, that the rejection phenomenon is something that not only we must, but we will learn to control by studies such as those that were just presented by Dr. Webb.
Dr. Cooley, will you close, please?
I was interested that each of the discussants recommends some form of preservation of the heart. Hypothermia has been advocated for this purpose, but I'm not convinced that it adds anything to the preservation. In the first place, the transfer of the heart can be accomplished in less than 45 minutes from the time it's removed from the donor until it's functioning in the recipient. Hypothermia and coronary perfusion simply delay this period of transfer. Moreover, I'm inclined to believe that hypothermia is not only not a good method of preservation, but I think it may cause injury itself. The most severe case of rejection that I've seen histologically was one which Dr. Richard Lauer described to us. This was a patient with an excellent B-plus match. We have not had such a good tissue match in our series. This patient had hypothermia. Histologically, the heart muscle was in the most deplorable condition of any I've seen, with fragmentation of the myocardium, myocardial fibers, and extensive infiltration. I would suggest to you that there may be an element of frostbite in these transplanted hearts. I think that one predisposes the heart to rejection. We have not had a single hyperacute rejection in any of our cases. I think that this is because we've been using normothermic conditions with a rapid transfer. We've used ischemic cardiac arrest now in 3,500 open heart operations. And I'm pleased to say that throughout the world, in the larger clinics where open heart surgery is being done, this has been widely adopted. In the matter of the indications for operation, Dr. Webb brought up an interesting point. He did not tell us the indication for cardiac transplantation in his patients. But if they were rheumatics or had a diffuse myocardiopathy, then I can understand why rejection became a problem, because we too are concerned about anti-heart antibodies. The lessons we have learned, I believe, are these: that one should not be so permissive with his patients postoperatively. These patients are on heavy cortisone therapy and absolutely feel great. They're hard to hold down because they're so enthusiastic and they want to go out as missionaries for procurement of donors and to support this procedure. I think we were too permissive in our early patients, and certainly we have studied them quite intensively. In fact, the chronic rejection episode began following 2 double masters tests done within an hour of one another. I think that we should continue our immunosuppressive therapy more intensively than we have done. We have put too much reliance in the antilymphocytic globulin, and I think that experience is indicating that this material will lose its effect after approximately 2 months. Therefore, one should keep up the azathioprine therapy over a longer period of time. Our patients who had chronic rejection had almost been withdrawn from the azathioprine and prednisone. In our current surviving patients, of which we have 7 in the hospital, these patients are ambulatory and come and go as they please, but they're under more strict regulation at the present time.
Our second clinical paper, Use of the Sutar Tube in the Palliation of Advanced Esophageal Carcinoma, by Jack M. Zimmerman and T.C. King. Dr. Zimmerman.
Unfortunately, the present status of the treatment of esophageal malignancy today is such that most patients, at some point or other in their course, require palliative treatment. Palliation, of course, includes not just an effort to lengthen survival, but an effort to make the surviving time as comfortable as possible. In patients with esophageal carcinoma, often the principal barriers to palliation are the presence of severe inanition and the presence of severe regurgitation, either with or without an associated aspiration pneumonitis. To get around these difficult problems, a number of techniques have been tried, including radiation, gastrostomy, extensive reconstructive procedures, and bouginage. and all of them have been fraught with difficulties of various kinds. It's been our concept that possibly the best palliation would result from restoration of a patent esophagus by the simplest possible means. Actually, such a procedure was suggested in 1887 by Charters Simons. In 1927, Sir Henry Soutar designed the tube which we have employed. We have felt that the Soutar tube has the advantage that it can be inserted entirely endoscopically and does not require either a thoracic or an abdominal incision. It's made of gold-plated nickel wire wound in coil spring fashion, and it has broad spiraled grooves in the stem to prevent slippage, a flange at the top to prevent slippage downward. It comes in lengths from 3 to 4 inches and in diameters from 5/16 to 5/8 of an inch. It can be inserted either under topical or general anesthesia. A Negus esophagoscope is used and passed down to the level of the tumor, and then a lumen through the tumor is carefully searched for. If no lumen can be found, we feel that an attempt to pass an indwelling tube should be abandoned. If a lumen can be found, it's dilated gently upward with a series of bougies, and then the last bougie is left through the lumen of the tumor. The Soutar tube is placed over the handle of the bougie and advanced with a special plunger down to the level of the tumor and passed into the tumor mass with its flange engaged at the top of the tumor mass. After the tube has been inserted, we get a plain film of the chest, and then in the next day or so, a barium swallow in order to check the patency and position of the tube. We have begun our patients on a soft diet immediately following the insertion of the tube. Now, we've had experience with 50 patients, personal experience of Dr. King and myself, in which we have inserted the tube. All of these patients had incurable esophageal cancer, incurable either by virtue of distant metastases or by virtue of local extension. All 50 of the patients were obstructed, and 18 of the 50 had severe regurgitation, either manifested by symptomatic reflux or the presence of fairly severe aspiration pneumonitis. We regarded any patient as obstructed if he could not swallow anything more than liquids. Now, the tumors lay at varying levels in the esophagus. The highest one was at 16 centimeters from the incisors, the lowest at 38 centimeters from the incisors. 3 of the 50 patients have had recurrent tumor following a primary resection with esophagogastrectomy. 2 of our patients have had fairly long obstructions, which required the insertion of 2 tubes in series. 24 of our patients have had radiation therapy following insertion of the Soutar tube. The survival data on these 50 patients: 9 of them died in the first month following insertion of the tube. 1 patient clearly died of the procedure. This was a patient in whom the esophagus was perforated with the tube, and he developed mediastinitis and died a day or 2 later. The other 8 patients, we feel quite confident the insertion of the tube did not contribute to their demise. They died of progressive disease. The other patients died over the ensuing 8 months. Now, as far as the effect on obstruction and regurgitation, the course over 3 months, initially 48 of the 50 patients were relieved of their obstruction. 16 of the 18 were relieved of their regurgitation. We regarded a patient as relieved of obstruction if he was able to swallow a soft diet or more, relieved of his regurgitation only if he was free of manifest symptomatic reflux and aspiration pneumonitis. Undoubtedly, some of the palliative effect which we achieved in these patients was due to their associated radiation. However, in view of the degree of obstruction and regurgitation which they had, we feel that the tube contributed materially to their palliation, particularly during the period prior to radiation-induced tumor shrinkage. I think it's safe to say that a number of these patients would not have tolerated their radiation therapy unless their obstruction and regurgitation had been first relieved. The only serious complication among these patients was the perforation resulting in mediastinitis and death. We had several patients who temporarily obstructed their tubes with food. This was relieved at esophagoscopy. We had several patients in whom the tubes became dislodged, particularly following radiation therapy, and these tubes either remained harmlessly in the stomach or passed on out through the intestinal tract. In none of our patients did we have a serious problem with hemorrhage nor reflux esophagitis. In substance, then, we feel that the Sutar tube provides a useful tool in dealing with certain problems that arise in certain patients with advanced esophageal malignancy. As with any tool, it must be selected carefully and used carefully. Unquestionably, in certain patients, some of the other types of tubes, which are a bit more complex to insert, may be preferable. We've described their use here strictly for palliation. We have a number of patients in whom we used it as a means of preparing the patient for definitive therapy.
Vanderbilt University's John L. Sawyers offers this comment concerning Dr. Zimmerman's paper.
It was not until my associate, Dr. William Alford, returned from a year over at Leeds, England, that we began to utilize the Sutar tube. We have now placed this tube in 21 patients. 13 of these patients had esophageal obstruction from advanced carcinoma, similar to the patients described by Dr. Zimmerman. 2 patients had tracheoesophageal fistulas following irradiation for carcinoma of the esophagus, and the tube was successful in allowing these patients to eat. 3 patients developed an esophageal stricture following irradiation treatment for esophageal carcinoma, and 1 had a benign stricture. 2 other patients are interesting since they had an extrinsic carcinoma blocking the lower esophageal outlet just above the cardia of the stomach. The primary tumors were from lung and pancreas, and the Sutar tube allowed these patients to swallow. In some of the patients treated for lesions other than intrinsic obstructing esophageal cancer, we have had difficulty in keeping the tube in place and have recently utilized a very simple procedure to maintain the tube in proper position. This is done by tying 2 long Dacron sutures to the proximal end of the tube, then bringing both ends of each suture through the piriform sinus onto the skin of the neck and tying them over a button. This is easy to accomplish and maintains the tube in satisfactory position. This idea is not original with us, but has been used by our British colleagues. I'd like to urge those of you who are faced with the difficult problem of providing palliation for patients with dysphagia from incurable carcinoma of the esophagus to consider utilizing this very simple and safe procedure to relieve intractable esophageal obstruction.
Dr. Zimmerman provides these closing remarks.
I think that often in dealing with patients with malignancy, it's very tempting to devote our attention and our efforts to cure, but there are situations in which hope of cure is gone. Then the problem is palliation to prevent as much misery as we can, and this does indeed require a great deal of patience, and that's for what I'd make the plea today, is that we continue to make every effort in those patients in whom we cannot cure them to provide them with as much comfort as possible in their remaining days.
And this, Doctor, is the end of this side of your reel. On side B, discussions of transfusion reaction, a reappraisal of surgical incidence and significance, and the surgical treatment of portal hypertension utilizing the side-to-side anastomosis. And to hear these, simply reverse the 2 reels or cassette on your tape recorder. The Audio Digest Surgery, Volume 16, Number 2, continuing a program of highlights of the Southern Surgical Association's 80th Annual Session. Once again, here is program moderator, Dr. Rudolph J. Knorr, President of the Association.
The next paper in this group, Transfusion Reaction, a reappraisal of surgical incidence and significance, Lloyd M. Nehus, and by invitation, R.J. Baker.
Annual usage of blood in the United States is approximately 6 million units per year. Although transfusion of blood in various clinical settings is acknowledged to be life-saving, reactions to these infused materials are common, reportedly occurring in about 2 to 10% of all recipients. Reactions fall into 2 major categories: immediate transfusion reaction, ordinarily observed within 48 hours of transfusion, and the delayed reaction with onset after 5 to 10 days. In the latter group are isosensitization with transfer of antigen and disease transmission, notably serum hepatitis. Meaningful information concerning the incidence of these late sequelae is almost non-existent. Furthermore, at least at this time, no effective means of prevention of either has been discovered. To be considered are those immediate transfusion reactions which are recognized during or soon after transfusion and which are reported in 50 to 75% of instances. A review of the incidence of immediate reactions to transfusion of 116,000 units of blood and blood products administered to patients at the Cook County Hospital, the University of Illinois Medical Center, during the 6 years 1961 to 1967 was undertaken. These were administered to 42,000 approximately recipients. A reaction was noted following 2,500 transfusions, that is, in 2.21% of units given. These reactions were seen in 2,293 recipients, or 5.42% of all patients being treated. Now, a standard transfusion reaction form was used in the determination of the parameters which were to be studied in this group of evaluations. Careful analysis of the reaction records in the 2,293 recipients showed the types of reactions as allergic, 45.6%, the most common, febrile, 43.5%, hemolytic, about 3 times what other institutions have reported, 9.9%, and miscellaneous, 1%. Circulatory overload is seldom reported to the laboratory, although it occurs commonly. The use of plastic equipment for blood and component collection has essentially eliminated air embolism as a complication. Serologically verifiable incompatibility of donor and recipient bloods was only observed in 83 of 227 hemolytic transfusion reactions, or 36%. The remainder of these reactions were not definable by currently available testing techniques in 144, or 64% of instances in which they occurred. Fortunately, the mortality rate in this latter group was quite low, only 3 deaths being recognized as due to transfusion reaction. Hemolytic transfusion reaction is the commonest life-endangering reaction which is encountered, the accepted incidence being 1 in about 3,000 units transfused. However, if all patients are included who experience frank intravascular hemolysis, even though asymptomatic, the true incidence in our series is 1 in 512 units transfused, or 1 in 187 recipients. Serious symptomatic hemolytic transfusion reaction occurred in 1 in 3,322 units infused, or in 1 in 1,209 recipients. 14 of these 35 recipients died, a mortality of 40%. 6 had serious underlying disease. The exact cause of death, therefore, could not be accurately determined. The 8 patients who obviously died of the transfusion reaction succumbed to shock in 3 instances and renal failure and metabolic causes in 5 others. Allergic transfusion reaction was the commonest type seen and was observed almost exclusively in patients who had received more than 1/2 unit of whole blood or plasma. Febrile reactions have been encountered almost as frequently as allergic reactions. It is likely that many of the reactions classified as febrile were, in reality, allergic, as most of these required more than 1/2 unit infusion volumes before symptoms developed. The symptom complex in the allergic phenomenon, by far the most common, and the key symptoms are itching and urticaria. Chills and fever overlapped, laryngeal edema and bronchospasm very rare. The suggestion of therapy for the allergic transfusion reaction is do not stop transfusion, Benadryl probably, certainly observation. Now, as far as the most serious aspect, hemolytic transfusion reaction, this was observed in three primary forms: frank hemolytic reaction with symptoms; second, post-transfusion hemolytic jaundice with few or no symptoms; and three, intraoperative diffuse bleeding or severe hypotension, presumably due to the hemolytic reaction. Hemolytic reactions may occur with very small amounts of whole blood or packed red cells infused, the smallest volumes observed in this group being 30 to 40 cc. As a rule, the earlier the reaction is observed clinically, the more serious the reaction and the greater morbidity and mortality. Treatment of the hemolytic reaction: ethacrinic acid and mannitol have been quite helpful in maintaining urine output. However, sodium infusion to alkalinize the urine and prevent precipitation of hemoglobin as acid hemoton in the distal tubule has been of highly questionable value, and steroids have not been particularly rewarding despite enthusiasm for their use. The exact pathogenesis of the shock and respiratory insufficiency in these patients is also unclear, but it's proposed that sudden pulmonary venular obstruction may occur in man as it does in study animals. Investigation of cell survival in normal volunteer recipients in our laboratory has yielded a small but definite number of individuals who are otherwise normal but who apparently destroy homologous transfused cells at a very rapid rate. Identification of the specific metabolic derangement in these patients is currently underway, primarily concerning adenosine triphosphate and glucose 6-phosphate dehydrogenase deficiency. Although various therapeutic regimens are proposed for the several types of reactions, the most effective treatment remains prevention and should consist of the following: withholding transfusions of whole blood or red cells unless absolutely necessary. Check and double check all identifying characteristics of each unit to be given. Know the recipient's identity by name and verify hospital number, and watch the patient closely for signs of reaction during the first 100 cc of infusion.
Discussion will be opened by Dr. Arlie Mansberger of Baltimore.
A couple things I'd like to point out. When we're forced to give massive transfusions, we're giving a significant acid load, especially when we give them rapidly. The pH of bank blood is 7. And if you let it sit around a while, it becomes 6.6 due to glycolysis. Now, this can compound, for example, the acidosis already present in a ruptured aneurysm and can affect hemodynamics. Within a few hours, this changes into an alkalosis, and a significant alkalosis develops by about the third postoperative day due to the metabolism of the citrate in the solution. The next point I'd like to make is that let us not kid ourselves, and when we replace blood, we are giving the bacterial defense mechanisms back to the patient. Dr. Oladart in our hospital has demonstrated that the complement titer, the phagocytic titer index, and the bactericidal titer of the serum are virtually zero in bank blood. And finally, with respect to prevention of transfusion reactions, especially the hemolytic variety, I wonder if the authors have used or have had any experience with the biologic test whereby 50 cc's of donor blood is given intravenously to the recipient, and after a half an hour, the Icarus index is compared with the pre-infusion sample. This has at least been proposed as a screening procedure in patients who have had large volume transfusion prior to the anticipation of giving another transfusion.
Discussion will be continued by Dr. Marion S. DeWeese of Columbia, Missouri.
I can find little in his presentation with which to take issue, although a few points do deserve emphasis. Firstly, we would prefer to administer blood with the patient awake if we have a choice in the matter. The signs and symptoms which herald the onset of a reaction are frequently obscured or delayed under anesthesia. Secondly, if the patient is asleep, unexplained bleeding may provide the first indication of an hemolytic reaction. Free plasma hemoglobin determinations can be done easily and rapidly and will provide the diagnosis if found to be elevated. Contrariwise, this is less helpful if the determination is delayed. Thirdly, we would agree that central venous pressures are helpful in the patient requiring multiple massive transfusions. However, as Guyton, Spencer, and others have shown, pulmonary edema may occasionally occur in the face of relatively normal or transient mild elevations in the central venous pressures. And fourthly, if the need for repeated transfusions is acute, we do not hesitate to restart a transfusion using properly matched blood as soon as possible, even though a hemolytic reaction has been identified. We would take mild issue with a statement which is made in the manuscript, which he didn't have time to go into, with a somewhat what we felt indiscriminate administration of fibrinogen in those hemorrhagic states suspected of being due to the so-called consumption coagulopathies. Certainly, prompt identification is mandatory of these patients with intravascular clotting, immobilization of fibrinogen and platelets, and excessive circulating fibrinolysins are to be salvaged. Because of the high incidence of hepatitis, which runs 20 to 40% in our own hospital, accompanying the administration of fibrinogen, and its relative futility during the acute state, we generally place more reliance upon fresh blood transfusion, epsilon aminocaproic acid, and heparin when we can identify this syndrome. Although the use of heparin appears paradoxical and requires some courage, it may prove to be life-saving. We generally reserve the use of fibrinogen for those patients in whom the situation is desperate, and we have objective documentation of the presence of marked lack of fibrinogen.
Discussion will be continued by Dr. Brown of Lakeland, Florida.
I rise to point out that there is another reaction that we as surgeons, I think, should be aware of, and it sometimes proves very confusing. And that is that even with blood, we still have a tissue rejection phenomena, much that we're hearing about today with kidneys and hearts, that it is no different than these tissues as far as rejection is concerned. And this is particularly true in patients who receive multiple transfusions, who have had transfusions in the past. Unfortunately, most of these reactions are not detected before transfusion by the usual cross-match procedure because the antigens involved do not show up in the usual procedures we have today. Indeed, we don't have any means of detecting most of the esoteric antigens, of which there have now been some, 300 or 400 identified on the red cell. The second reaction that I'd like to speak about is, again, the emphasis on the bleeding, which all of us have seen and which can be catastrophic. And I would agree with Dr. DeWeese that in our experience, the best therapy for the bleeding syndrome, which comes on so abruptly after an incompatible transfusion during surgery, may be more transfusions of compatible blood, and particularly fresh blood, because in our experience, it's the acute, profound thrombopenia which occurs and which can be measured in these people. Sometimes the platelets dropping out completely within a matter of minutes that seems to be the culprit.
Dr. Baker, will you close, please? Dr. Robert Baker of Chicago.
The discussion which has ensued from the paper that Dr. Nias and I have presented has given me the opportunity to present 2 or 3 more papers, but I'll refrain from doing that and try and answer the very interesting and stimulating questions that have been raised. First of all, with regard to Dr. Mansberger's question about biologic testing, it's obviously ideal to give a patient a very small dose. I would suggest 20 or 30 ml of a suspect donor blood and then measure plasma hemoglobin in 30 to 60 minutes. Plasma hemoglobin is freed very rapidly from incompatible cells, and if this were clinically feasible, I think it would be an ideal procedure. Unfortunately, most of the time when we transfuse, at least at the Cook County Hospital in Chicago, we're in a big hurry, and we really don't have the time to do this, although we would like to do so. Dr. DeWeese has raised a question that I was sure somebody would, and that is why we see so many more hemolytic reactions than other people are reporting. I think for 2 reasons. Number one, when you become interested in a problem and begin to look for it, it becomes apparent much more frequently than you thought it existed. And I think that what has happened is that as we have become more and more interested in hemolytic transfusion reaction, both early and late, we have found a number of patients who have developed serious icterus on the 2nd, 3rd, 4th, 5th, and even later periods of time, who in previous years simply weren't reported to us. And I personally am convinced, and one of the points that the manuscript attempts to make, is that hemolytic reaction is much commoner than we give it credit for being. It's true that the catastrophic series of symptoms do not occur very frequently, but frank intra- and extravascular hemolysis is extremely common, and we feel that it should be reported and will be reported more frequently in the future. As far as the indiscriminate use of fibrinogen, I couldn't agree more that this is a hazardous undertaking. It should never be used unless the patient is shown, at least by some crude testing, to be fibrinogen deficient. Now, the easiest way for me to do this is to do a Lee-White clotting time, and if the fibrinogen is seriously below 100 milligrams per cent, the normal concentration being 350 to 450 milligrams per cent, if the fibrinogen falls below 100 milligrams per cent, the Lee-White clotting time will be delayed, and adding topical thrombin to a sample of blood will ordinarily not correct the Lee-White clotting time. So with this sort of crude intra-operating room or bedside test, you can at least roughly guess that fibrinogen is deficient. Dr. Brown's point about tissue rejection, I think, is an extremely fascinating one. We didn't mention leukoagglutinin reactions, which destroy white cells, cause febrile reactions, are probably the cause of most of our febrile reactions, but all sorts of tissue rejection does occur when one transfuses whole blood, white cells, and platelets, and I think it's extremely important to keep in mind that the delayed hemolytic response, which is the important issue, is one which destroys the value of transfusion, at least from a late standpoint. The bleeding which occurs, of course, should always be treated with fresh transfusion. Let me point out again, the blood should be less than 24 hours old for maximal platelet transfusion. And number two, and most important, it must be recross-matched. It is impossible and disastrous on occasion to use blood which was cross-matched before the first and offending transfusion was given.
Paper number 4. The surgical treatment of portal hypertension utilizing the side-to-side anastomosis, Dr. Thomas B. Patton.
There has been considerable variation in opinion over the years as to which type shunt is the best for portal decompression. This is understandable in the progress which has been made in understanding the complex function of the liver and the hemodynamics of the portal system. As a result of the observations in this series of patients for whom the side-to-side portocable anastomosis was carried out for portal decompression, this type of shunt has clearly emerged as the procedure of choice. Using the anesthesia and the techniques hereinafter discussed, more patients have been salvaged and mortality has been maintained within reasonable limits. All of the patients in this series presented themselves with massive variceal hemorrhage. It was in 1946 that we first began to use tamponade for these patients, and it has emerged as the ideal treatment for the control of hemorrhage in these patients with sick livers. Borderline liver function and decompensated homeostatic mechanisms have prompted our reliance solely in tamponade. The double balloon tube is used, and we've divided the period of tamponade into 6 4-hour periods, deflating the upper balloon after 4 hours, and if there is blood in the gastric aspirate, we have reinflated the upper balloon and continued this in this fashion. The longest patient in which tamponade was successful was 15 days of intermittent tamponade, and it was possible to perform a side-to-side anastomosis in this patient electively. Early on, we tried transthoracic transesophageal ligations in this group of patients, and the mortality was 100%. This was due to breakdown of the esophageal suture line and death from the resulting mediastinitis. We feel the transesophageal ligation should be reserved for people with extrahepatic obstruction. Insofar as the selection of patients were concerned, there was no arbitrary or rigid selection of patients presented in this particular series. Any individual resuscitated from acute variceal hemorrhage was considered to be a candidate for the side-to-side anastomosis. No patient that was actively bleeding or in coma was considered for a shunt as an emergency. All shunts were performed electively. Insofar as the anesthesia is concerned, for the last 8 years, we have come to rely solely on the combined type of anesthesia, and this consists of high spinal, sodium pentothal, and succinylcholine given intravenously, intubation of the trachea with administration of nitrous oxide and oxygen. The advantages with this anesthesia are excellent relaxation, loss of harmful reflexes, good ventilatory control, protection of the airway, no residual from relaxants, and good early ventilatory capacity in the recovery room. Disadvantages are few, but it must be pointed out that the sympathetics are not intact and the circulation has to be supported. This combined anesthesia has permitted, we feel, an extension of the application of the side-to-side anastomosis in poor risk individuals. Insofar as the operation is concerned, we have used the position of tilting the patient 30 to 40 degrees to the patient's left side, and this represents Hunt's hornpipe position, which fixes the diaphragm in an inspiratory position, depressing the liver. The method that we'll use, the hepatic artery is retracted, as well as the common duct, and further, the vessel is cleaned of the troublesome and aggravating fibrous tissue and lymphatics. It should be pointed out that in 5 instances we have found anomalous hepatic arteries, 3 of which have come from the superior mesenteric and 2 from the aorta itself, but these can be usually manipulated out of the way. Another thing which is given as a reason for the inability to perform the side-to-side anastomosis is the fact that there is caudate lobe hypertrophy. We found this in 3 instances, in 2 of which a vein graft was used, and in the 3rd, a neck fistula was performed. I think it's important to point out that we do use the Blaylock intima to intima stitch for the anastomosis. This is an everting stitch, does prevent the turn of advent tissue, which provides a nidus for clot formation. Insofar as portal pressures are concerned, we feel that these have provided no prognostic significance and therefore have not performed them during the shunt, and portograms are not indicated in these patients with intrahepatic disease, since palpation will adequately demonstrate patency of the portal vein. The portograms are more properly reserved for those individuals having extrahepatic portal obstruction. The side-to-side porticable anastomosis has been performed in 148 patients. 17 patients had extrahepatic obstruction, 76 patients had Laennec cirrhosis, and 49 patients had post-necrotic cirrhosis, and these diagnoses were confirmed by liver biopsy at the time of operation. We use the classification by child as a basis of comparison for patients in this series. He classified these into A, B, and C according to liver function, and only the patients with extrahepatic obstruction made the A group. In Class B were a few individuals with post-necrotic cirrhosis, and there were 112 individuals that were in Class C. The immediate postoperative mortality in Class A was 5%, in Class B it was 11.1%, and in Class C was 17.8%. Almost all of the deaths in Class C were due to bleeding or coma, and the late mortality in Class C, 25%, was attributed to coma and bleeding. There were 12 patients in this group of the late mortality who died of causes unrelated to liver disease. Examination of the shunt on postmortem examination in 16 patients revealed that the shunt was open in 13 patients and closed in 3. No prophylactic or emergency side-to-side shunts have been performed in the last 6 years. While only 1 prophylactic shunt was performed early in this experience, with survival, precise indications are lacking and must be more sharply delimited. Our early experience with emergency shunts, 5 with 100% mortality, has increased our confidence and reliance in tamponade for the control of massive variceal bleeding. In conclusion, regardless of the classifications designed to evaluate the operability of these patients, it must be coupled with clinical evaluation and an indeterminate period of so-called medical management to bring these patients to optimal condition for an elective shunt.
Dr. Patton kindly allowed me to see his paper and asked me to say a few words. I suppose because I had the privilege of seeing the start of this work when he and I were both in the Department of Surgery at Wayne University in Detroit some 20 years ago, just after World War II. I think Dr. Patton is to be complimented on his careful follow-up of these patients over this period of time. In view of the reported dissatisfaction in some hands with tamponade, I'm interested in his report of uniform success with esophageal tamponade in controlling the acute bleeding and in the fact that they have done no emergency shunts. The increase in the proportion of post-necrotic cirrhosis in his series also is interesting in that they now have 1/3 of their patients in the post-necrotic cirrhosis group. I think his low mortality, as he reported it to you, is particularly commendable in that approximately 3/4 of his patients lay in the poor risk group. And Dr. Patton?
I would not have any of you think that this is a perfect procedure, the side-to-side anastomosis. We have been plagued with all of the troubles and difficulties that others have had in trying to devise a satisfactory procedure. There have been instances of coma in the postoperative period, most of which we've been able to treat by restriction of protein and the various antibiotics. I would, however, commend to you McDermott's work on colon exclusion, because in the recent past we have had 2 individuals who were so refractory to protein that it practically amounted to going into coma when passing a butcher shop. They could take almost no protein at all. And these 2 individuals have been completely resuscitated by the use of colon exclusion. I would suggest to you that this is a procedure which is tailored to meet the metabolic deficits of these individuals, is preferable to colon extirpation, which is a big procedure for these people to handle, and also is preferable to the anastomosis of the cecum to the side of the rectosigmoid or sigmoid in an effort to divert the flow of bowel content throughout the small bowel.
And this concludes this edition of Audio Digest Surgery. Our thanks to all participants and to the Southern Surgical Association. Audio Digest Surgery is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. All rights are reserved.